Good afternoon, everyone, and welcome to today's CHEST webinar on the COVID-19 therapies based on some of the new updated guidelines. So I'm going to give a little bit of time for some of the participants to start joining in. While that happens, I want to introduce myself. My name is Casey Cable. I am an assistant professor here at VCU Hospital Health in Richmond, Virginia. A couple of quick pieces of note keeping. If you could please direct all of your questions to the chat. I'm going to try to, as best as possible, incorporate them and compile them and ask the panelists when possible. So it looks like our participant numbers are increasing, so I'll give them a little bit more time. Talking about steady, so why don't we meet our panelists for the day. Barb, would you like to introduce yourself?
Oh, sure. Hi, I'm Barb Jones. I'm from Salt Lake City, Utah. I'm a pulmonary critical care doc, and I study pneumonia and practice in pneumonia.
And Stefano?
Sure. My name is Stefano Liberti. I'm a professor of respiratory medicine at the University of Milan, Italy. I'm into respiratory infections, and I've been working in a respiratory ICU COVID-19 since almost 1 year.
Great, thank you so much. And I really thank you both for taking time out of your very busy days to discuss some really important new updates to some not only national but international guidelines. So let's starting with that, Stefano or Barb, what are your key messages or kind of takeaways from these new updates that have come?
I'll start, Barbara. Okay, so I think that Casey is we learned a lot from the COVID-19 pandemic. And I remember when almost 1 year ago, we were facing a brand new disease, and we were trying to understand which kind of drugs we were supposed to give to our patients. And then at that time, we were taking drugs from different diseases like SARS, MERS, or common pneumonia. And now we know that we were not doing good. But at that time, we didn't have evidence about this disease. Now we are in a completely different phase. Now we are in a phase where some good evidence came out, and we were now able to give some recommendations about drugs for COVID-19. And if you take a look at some registry like clinicaltrial.gov or whatever, you are seeing that a lot of randomized controlled trials are coming out, and this is really good because we will improve our accuracy in giving recommendations. And if you also take a look at the different the scenario of guidelines or consensus statement or documents published worldwide, you can see that these guidelines or these statements has different conclusions. And the main reason is because differences in guideline methodology can lead to different conclusions. So it's always very, very, very important to understand what is the methodology. Today, the guidelines by the European Respiratory Society came out according to 11 PICO questions and the grade process. These are living guidelines, and I think that Barbara will integrate this with the NIH one. These are living guidelines based on a strong methodology, continuously updated, and this is the way to work nowadays. So it's really, really important, and I hope we can use new evidence to better treat our patients.
Yeah, and I'll just add to that and follow. I think one of the really amazing things about COVID is I've really thought a lot about it as a stress that just exposes failures, in every system that you're part of. And one of our systems was science, and science is used to having a lot of time and being pretty slow. And also the creation of guidelines is also a very slow process. So the community-acquired pneumonia guidelines, for example, took us about 12 years to in the IDSA ATS that took us 12 years to improve upon. And we had to produce, living guidelines very quickly for COVID, so I was part of creating something for clinicians at the VA hospital system, and we wrote something in 7 days. So a little bit different of a time warp. And one of the things that was really amazing was that people really responded and put up some really great science actually in a very short period of time. The United Kingdom, I really think, just really showed off their wonderful infrastructure for research and so created really good, solid evidence in a really short period of time.
No, yeah, that's pretty astounding. I mean, it's been an interesting year by far, but no, I think I agree. I really like, the key message of different methodologies. I think that definitely needs to be, considered, as well as we're now having a lot of pure evidence-based, randomized controlled trials, that it's really kind of leading a lot of clinically what we do. So I will leave it up to you guys if you guys wish to start talking about kind of one of the newer players on the board, our IL-6 receptor antagonist. Tocilizumab, I know, is definitely has been quite a bit in the headlines, and I think is definitely something new that has popped up in these guidelines. I don't know if you guys want to focus on that, because we know with the REMAP and the recovery trial, I think there's some opportunity to kind of talk about some of the evidence that kind of led us to these recommendation changes.
Sure, and I can kind of start by talking about how we generated evidence so quickly. So one of the things that was novel SARS-CoV, we didn't really know what kind of outcomes we're going to expect, what kind of prevalence of disease, how many cases we were going to see. So it's really hard to design studies when there's a lot of uncertainty around the number of patients, the effect size that you would estimate. You can't exactly do a power analysis and know exactly when you're going to stop your trial. So they had these, and you also don't know, we wanted to try a lot of things really fast to, and make sure that once we found something that was effective, it was, disseminated and published. So the adaptive trial design is really cool. So what we saw, the NIH and the World Health Organization, and then the REMAP CAP, study was, these are all adaptive trial designs. And what they do is they enroll patients on a really flexible kind of real world approach. So there's not a lot of exclusion or inclusion criteria. Generally these were generally hospitalized patients, but really otherwise not a lot of exclusion criteria. You could opt in or out on different treatment arms. And so you could always have a study that, a provider might decide that a patient doesn't, fit the dexamethasone trial, but they might want to fit the hydroxychloroquine trial. So you could opt in or out of different study arms. And then, you could also establish a benefit based on kind of some nice statistical analysis around how many people do you really have to have, and depending on what effect size you're starting to see, to establish whether something's beneficial, harmful, or futile, so that you can move on and really kind of close the study to move on. These are all open labeled trials too, so that means that there's no placebo control. That makes it really good because the physicians don't have to worry about, they know exactly what the patients are getting, and the patients know what they're getting. And it's also, you can use the drugs at hand. You don't have to use these blinded study drugs that take forever to process and envelope and all that. But the pitfall is that it is an open label design. So that's the one kind of thing about the science behind COVID-19 treatments, is that these are all non-blinded, non-placebo controlled studies. So I always think about that in the back of my mind when I'm trying to interpret how good they are. So that's kind of just an explanation of the design. I don't know if Stefano, you want to move on.
No, this is great. It's a pragmatic design that is really quick, helpful, consistent across different studies, because we know that the recovery platform data coming from the recovery platform has been confirmed also externally by other research groups. So It's been a huge thing. Now the question, Barbara, is how we can use this adaptive kind of platform for diseases other than COVID-19, because it's really good, and there might be some space, some rooms for other diseases. And Casey, you wanted to talk about IL-6 receptor antagonist monoclonal antibody a little bit,
yes,
right?
Yeah, tocilizumab, I know, is really hot in the news and in discussion in a lot of the ICUs and around the world.
So first of all, we need to think about the rationale, because actually there is a rationale about using IL-6 receptor antagonist. A rationale coming from different observational studies since at the beginning of 2020, showing that patients who have elevated levels of IL-6 were patients who were dying more. So there was an association with increased mortality, and this moved all the study on this specific pathway. At the end, I think that we have some interesting evidence, because if you take a look at the literature, we have more than 3,000 patients enrolled in IL-6 receptor antagonist monoclonal antibody, and other 3,000 in the usual care. The majority have been treated with tocilizumab, but we now have data also on sarilumab. A couple of days ago, a paper on Lancet Respiratory Medicine came out, and so there are interesting study. The ERS guidelines, the task force did a meta-analysis looking at the effect of IL-6 receptor monoclonal antibody on mortality. And from 8 different studies, and they found no effect, no significant effect on mortality. On this meta-analysis was 2024 versus 29 with an odds ratio of 0.90, something like that. But the point is that the 2 major studies that offered the data for this meta-analysis were the recovery from one side and the REMAP-CAP from the other side. And these 2 larger studies actually demonstrated a significant reduction in mortality. And now this opens a lot of interesting questions. I would like maybe to involve Barbara in some answers. The first question is, what is the role of IL-6 receptor antagonist if the patient now, if for COVID-19 patient now the standard of care is corticosteroids? So should we interpret, should we give this drug only if the patient is receiving or failed a treatment with corticosteroids, for example? This is a very important question, because after the data of the recovery on dexamethasone, now we have data about this as a standard of care. And the second question is about the patient selection, because we might want to follow the inclusion criteria of the recovery, and we might with the CRP rule, the 75 milligrams per liter threshold, for example, or we want to follow up the REMAP-CAP inclusion criteria. So there are interesting questions. What do you think, Barbara?
Yeah, I mean, all of it is really interesting. And one of the things that I think is going to be really interesting is to see, to follow practice and see, when the recovery trial came out, it was a single trial, it was open label, but it was big. And it had 2,000 patients in at least each arm. And it was really compelling. The effect size was really large. I think that was something like a 8% absolute difference in mortality. And very much for the mechanically ventilated, it was very compelling. For the hospitalized with oxygen needs, it was still compelling. And then there was no evidence to support dexamethasone non-hypoxemic patients, even if they were hospitalized. So that changed practice like almost overnight, it seemed. Within 2 weeks, I think all of my friends were using dexamethasone for all of our patients. It was really easy for us to reach for that medication. I think it was because it was familiar, it was cheap. It's about a nickel a dose, so that was a really easy thing for people to adopt. Tocilizumab's a little bit different. First of all, the original studies didn't seem to have as much benefit. It did seem to be, the both REMAP-CAP and the recovery trial, the vast majority of those patients were also on steroids at the time, which is why, the guidelines all recommend, I think ARS and NIH for sure recommends that you not use tocilizumab in isolation, that you use it in conjunction with dexamethasone. And so, we're treating one pathway with a very blunt immune modulator, which is dexamethasone. And then we're targeting a very much more targeted path of immune response with tocilizumab. And so tocilizumab, the addition did seem to be beneficial, but it's an absolute risk, difference of about 4%, which, in critical care, that's huge. That's still, amazing. Anything that we can do to improve our patients' outcomes is great, but it's not as big an effect size as the dexamethasone effect. And tocilizumab is new. I don't use it, for COPD exacerbations. I am not used to tocilizumab, and it's expensive. And so I think it'll be really interesting to see how many patients really receive tocilizumab. The NIH guidelines really looked at the two, these are, again, the two largest, most well-conducted studies are the recovery trial and the REMAP-CAP, both those tocilizumab and sirolimus arms. But both of those were pretty compelling. But timing was kind of everything. They were in patients that were receiving, that were fresh admits, on dexamethasone already. And so NIH kind of restricted its, conditional recommendation for patients that are new admissions to the ICU, receiving, high flow mechanical ventilation or NIV, and, appear to be progressing. So they used some language in there that, kind of suggested that this is targeting that immune response on top of, whatever we're treating with dexamethasone. But I think it'll be really interesting to see what people do with the REMAP-CAP and the recovery trial, because there's a lot of other ways you can generalize those findings beyond just doing exactly what the study did. I think it tells us a little something more about, the heterogeneity of the immune response. But for some patients, we are using these targeted immune modulators is probably something that we need to explore more.
And in those guidelines, and you're right, there is a little bit of gray zone in some of their terminology and the NIH guidelines in terms of tocilizumab. They talk about, rapidly acquiring oxygen needs who have significantly increased markers of inflammation. In parentheses, recovery used a cutoff of CRP of greater than or equal to 75. And there's been some discussion in the chat of, well, what practice do you guys use? And how do you determine if CRP is from another infection or not?
That's a great question. Stefano, I want to see what you think first.
Sorry.
So now So we follow the ERS guidelines unconsciously because they came out today. But looking at the recommendation, we were doing the same. So the concept is that it's difficult to identify the ideal patient population that who could benefit from tocilizumab. However, the recovery found a benefit in addition to steroids. So if steroids are also recommended for patients requiring oxygen and ventilatory support, now we would expect tocilizumab to be given in patients also receiving steroids in most of the case. We also know that TOCG is expensive. So what we are doing now is to offer IL-6 receptor antagonist monoclonal antibody tocilizumab in my clinical practice to adults hospitalized with COVID-19 requiring oxygen or ventilatory support that already had steroids and failed, or they are receiving steroids. And another important point from the REMAP-CAP study is the timing. So the first 24 hours after receiving non-invasive or invasive ventilation, and then the category of patients who had a progressive disease. So this is the kind of people we are thinking about undergoing to. They might benefit from the addition of IL-6 receptor antagonist antibodies. And actually, this is also the recommendation published by the ERS Society. It's important to remember that according to literature, we should not offer tocilizumab or any IL-6 receptor antagonist to patients who do not require oxygen. There is a low quality of evidence according to the ERS guidelines, and the recommendation we came out with is conditional, but this means that there are some data supporting that.
Yeah, and I think like the broader question is also, how do we characterize the immune response in a patient, in an individual patient? Using the biomarkers that we have available right now, they're pretty blunt diagnostic tools. And what we found, before COVID-19, there were a lot of studies that were trying to examine where these biomarkers fit. Were they useful? Are they helpful beyond our kind of clinical decision-making based on other more routine clinical manifestations? Procalcitonin, we really are trying to find a good use for it. It doesn't actually seem to improve practice if you actually study it in an implementation, study for looking at decisions around antibiotics. Or now, does it tell us something about the immune response? It probably does, but especially for COVID, it kind of highlighted that you can have an elevated procalcitonin and not have bacterial infection. You can also have no procalcitonin and have an overwhelming bacterial infection. It can be related to malignancy. It's a very non-specific inflammatory marker, and so is CRP. And so is it telling us something about the patient's likely benefit from a targeted immune modulator? I mean, the data from the REMAP-CAP study actually show that maybe a little bit, but does that generalize to individual practice? Where, does that still tell you whether my patient, Mrs. Wilson, right in front of me, will actually benefit from a drug if she has not an elevated CRP? I'm just not confident enough, in our ability to really characterize the immune response with the tools that we have at hand. I think around the corner, and this is again, COVID exposing failures. So COVID, I think, probably exposed the big failure in our ability to understand the immune response at all. It's a very complex system, and it has a lot of ins and outs, and we have very blunt tools to really characterize it right now. Now, I think that a lot of the really cool science coming out of COVID-19 is around better understanding the immune response. There's some great papers coming out of the Northwestern group that's really looking at the inflammasome and using flow cytometry and shotgun metagenomics and really coupling that with microbiome studies. So we're really starting to understand the host pathogen interaction better. Does this help me clinically yet? No, but I think it made us all hungry for better diagnostic tools, better, actual precision that, we can actually understand the immune response a little bit better. Yeah. In lieu of that, I'm not sure if I'd really trust a biomarker either way. If I really had a fresh progressive patient that seemed like they were in that, phenotype of a patient that might benefit from tocilizumab, I might be tempted to use it regardless of their biomarker stuff. So That'd just be my 2 cents.
Yeah, if I can add something a little bit, Barbara, is that both in clinical practice and according to guidelines, we tend to have two different way to stratify patients. One is according to the severity of the gas exchange. So, for example, there is a nice figure we came up with in the ERS guidelines, dividing the treatment according to patient not requiring oxygen, patient requiring oxygen, and patient requiring non-invasive or invasive ventilator support. And then if you take a look at this kind of stratification, you see that tocilizumab and IL-6 receptor antagonist goes into the group of patients requiring either oxygen or ventilator support. This is one way to stratify patients, and then you can integrate this when we are discussing about steroids and IL-6 receptor antagonists with the inflammatory status. And one biomarker that we use, for example, in clinical practice a lot during the first wave was ferritin, because at that time we were using anakinra as anti-IL-1, and there are some observational data on the use of anakinra and other anakinra in patients with COVID-19. And we were using ferritin to decide during a multidisciplinary discussion with our immunologist, those people who deserve a treatment with this drug, and then follow up ferritin during follow-up to decide when to stop anakinra. And this was on top of steroids at that time. So there are CRP, there is also a ferritin for specific drugs and for specific patients. I don't feel confident to say that one is better than another one. Maybe for procalcitonin, then we tend to look at procalcitonin to decide maybe to increase or not our suspicion of a bacterial infection over COVID-19, and to decide if to give or not antibiotics. But as you mentioned, it's highly variable across different patients.
Yeah, and sometimes I think that maybe we should be thinking about these biomarkers similar to dynamic assessments of like fluid responsiveness, right? So it's the key word is dynamic. Sometimes, if I could convince my healthcare system to pay for daily procalcitonins and CRPs, would we actually learn something, about that patient's immune response, following it across a time course? One of the things I think is the most underutilized, maybe, I think we implicitly use this a lot, but is the time course of disease. So one of my colleagues in Idaho coined a term called the COVID clock. So when I think about, is this patient, what phase of their disease are they in? Are they in the early phase of viral replication, or are they in the later phase of the immune response? And mapping the time course to actually their clinical manifestations, I think is really powerful and helps us maybe unpack, some of the importance of the sequence of giving these medications in different phases. Where we deviate, where our patients deviate from those patterns, I think is something that's where we can start thinking about complications of COVID-19. If a patient's coming back 2 weeks later, is that, something different, kind of helping people fit their patients into a pattern, I think is a good thing.
And also, if we want to talk, to end up with the IL-6 receptor antagonist story, we should remember that actually looking at the data from randomized controlled trial, no major safety concerns were identified. So from a safety profile, this is another important thing to remember. So the combined endpoint of requirement of mechanical ventilation and death was reduced with an odds ratio of 0.74, and no major safety concern were identified. So this means that we have room for new randomized control trials to better identify the population, the responders to tocilizumab or other IL-6 receptor antagonists.
So it sounds like you guys have been kind of talking a lot about, there's a lot of individualized, treatment of patients, with COVID-19. And I think that's where, there's a lot of talking about that, especially with different inflammatory markers and trying to figure out which ones mean what. I know that there's a lot of discussion in the chat and a lot of, understanding of, is 6-methylpred equivalent equal an equivalent for everybody? Not equivalent, the equivalence of that, but is that something, and once again, yes, the guidelines give that number, that's what's been studied, but what do you do in your practice, and how do you truly individualize therapy for our COVID-19 patients?
Yeah, that's a great question. I'd like to kind of start with thinking about two types of generalizability. So when I see a lot of times a randomized control trial or even observational study in the literature, I'm always, as a clinician, thinking about generalizability, which would be clinical generalizability, meaning, can I, use this study? Does this study apply to my patients? One of the things to point out with the recovery trial versus the United States experience is the recovery trial was done in the UK, where there aren't a lot of very elderly patients in the ICU. So in their mechanically ventilated arm, they've had very few patients who are older than 80. And in the United States, in my ICU, at least, I have a lot of patients who are older than 80. And so that would be an example of the recovery trial wasn't exactly clinically generalizable to my very old patients that had COVID-19. And so I thought, well, that could, steroids and other immune modulators could be more harmful to my population than maybe this study. But then there's scientific generalizability. And that's even if it doesn't generalize clinically to my population, it tells us something about the underlying, pathogenesis, pathophysiology of disease, and being able to target my therapies, according to the understanding of that disease. I think that's where these studies are very useful, even if they're not exactly the same population as mine. And so thinking about what I do to tailor, dexamethasone was something where we just kind of used that dose. It was interesting once the tocilizumab trial, the data started to come out, is, there were a couple different responses, at least in my group. So one response was, tocilizumab, never heard of it, I don't really want to use it. The second one was, that was very few people, but the second one was, oh yeah, I'm going to use it exactly the way this study shows, and the guidelines are saying this is the dose. Great, easy, But the third, most of us group was, gosh, what does that tell us about the immune response? This might mean that I need to target the immune system for some patients a little bit differently. And so some of us, that made us increase our dex dose or our duration, which is kind of interesting. But yeah, it does. So in my personal practice, I've honestly had a couple of patients where I've continued dexamethasone a little longer because they still seem to be just in this really prolonged, the trial was 10 days, but what happened after that 10 days? For some patients, they seem to still be in this cytokine storm inflammatory state. I want to treat that with something. And then when the tocilizumab trial came out, that kind of gave us a little more information that, maybe a yes and approach. So I think some of us, that is one way to tailor. But, another way to tailor is just being nimble, so if a patient dramatically improves, I'm not sure if they really need, 10 days of dexamethasone, and that can be harmful, so that's another thing is, shortening the course. Remdesivir definitely was another one where in the United States, the NIH guidelines actually came out with a statement for remdesivir as we should all be using this. And many of us did adopt remdesivir really pretty readily. And now we're kind of in this de-adoption phase because now, the additional studies came out. It doesn't actually seem to be as beneficial, and it kind of pathophysiologically, it makes sense to try to target viral replication in the early phase of the disease. So a lot of us are, starting to de-adopt remdesivir, especially in our hospitalized patients that are more than 7 days out. So that's another kind of tailoring a little bit, is putting a patient on the COVID clock and really thinking about the timing. How far are they into their immune response? What kind of immune response does it seem to be characterized by? Do I need more steroids than, the trials suggested? Those are a few things that I've seen in my cooperative practice.
I agree. And you, interesting note on the remdesivir, because that is the one major difference, at least that I could see between the ERS and the NIH guidelines, at least the new updated ones. Is that the NIH, they don't recommend use of remdesivir in patients in the ICU.
Right. Yeah. And so that was a change, before it was remdesivir for everyone.
Exactly. Just wonder, what's your take, not just on the remdesivir, but also on just individualized therapy of corticosteroids?
Sure. Do you want me to take the remdesivir story first?
Because
absolutely.
We'll start there, and then I think.
Oh, I'd love to hear that story of how the ERS kind of.
Yeah, we had a big discussion within. We had a big discussion within the ERS task force about remdesivir, and so the point is that so the remdesivir showed some effectiveness in vitro against SARS-CoV-1 and 2 and MERS, and this is the reason why, especially in the beginning, we were really into this drug. And there are some studies that that need to be explored and have been explored during this month. The first is the ACTT1 study. This was 500 patients treated with remdesivir and 500 treated with placebo, roughly. And the study showed a reduction in time to recovery and length of stay. And the primary outcome was the recovery time that was reduced by 5 days. And then gave us some hope about that. And then came out the Solidarity trial, which found no benefit in mortality. And these were more than 2,500 patients in remdesivir and 2,700 or something in controls. And there was no impact on mortality. So there was no significant impact. And they also included a meta-analysis, including the ACTT1. And when we decided to tackle the PICO question about remdesivir, we ran a new review, and we found very, very similar results. So the mortality was not significant, and there was also no increase in adverse events. The point is that the ERS panel thought that actually time to recovery and length of stay were relevant clinical endpoints, although there was no benefit in mortality. However, all these benefits were present in just one randomized control trial, and we thought that the benefit was modest. So we discussed a lot about remdesivir. We voted, and at the end, there was no majority in favor of a recommendation for, and there was no majority recommendation against the use of remdesivir. So the risk-benefit ratio is uncertain, and and we were not able to identify also a specific population of patients that were benefit from remdesivir. So at the end, if you take a look at the recommendation, the guidelines say no recommendation regarding the use of remdesivir in people hospitalized with COVID-19 and not requiring invasive ventilation. But we were able to give a conditional recommendation based on moderate quality of evidence for those who required invasive mechanical ventilation, and we suggest not to give remdesivir to these patients. So this was the final recommendation coming from the ERS living guidelines.
Thank you for that insight.
Yeah, and the second question, Casey, was on steroids, and I think that we need to have a very clear in mind the use of steroids, because actually the rationale behind the use of anti-inflammatory drugs or steroids is strong, and is also strong in patients with a severe disease, I agree with Barbara about adverse events and patient population, because actually, if you take a look at the recovery trial, the recovery did not report a detailed information about safety of steroids. So we have limited evidence about possible adverse events of steroids, and this is important, especially in.
Oh. I think we lost him.
Yeah,
risk
I agree.
benefit ratio is favorable for steroids. The results are significantly different between of patients, and this is the reason why the recommendation by the ERS guidelines is strong for the use of steroids in patients who require oxygen, NIV, or invasive ventilation, and it's also strong not to give steroids to patients hospitalized with no requirement for oxygen or ventilator support. So this is the guidelines looking at 6 randomized controlled trials and a meta-analysis. Well, the majority of the evidence comes from the UK recovery trial, more than 2,000 patients. We all know this study. A significant reduction in mortality for people receiving invasive ventilation. Significant, although lesser in people on oxygen therapy, and no mortality benefit in patients hospitalized not on oxygen therapy. So this is important to remind. Open questions. What is the optimal molecule? I can tell you what I'm doing in my clinical practice, but this is outside of clinical guidelines, because if we look at the evidence, we don't know what is the optimal molecule, what is the optimal scheme, dose, timing, duration of treatment, long-term side effect. Maybe it works in other subgroup of patients we were not able to look into. And also the tapering of the steroids is another interesting topic, especially for those who are developing post-COVID-19 fibrosis at CT scan. And then there is the big issue that is the use of high dose of steroids for people who are not responding without outside of any evidence, but there are people in clinical practice doing this. So there are a lot of questions that need to be addressed in the next future.
And I'd love to add just also, I think Stefano brought up another limitation of the studies. They were, phenomenal and huge numbers and, very generalizable to clinical care, but the ability to follow patients, because they were stood up so quickly and the goal was to enroll a lot of patients. The follow-up is really pretty limited. Once those patients were gone from the hospital, they needed to end up, in the UK registry, that was the only way they could follow them. And so there wasn't rigorous follow-up. There weren't study coordinators contacting these patients. There are no long-term outcomes about any of these studies. So a huge open question, I'm sure all of us are thinking about this ourselves, is what are the downstream consequences of our acute management of these patients? And some patients are going to have long-term complications. The other thing, anytime I see a randomized controlled trials and I see an aggregate benefit, there's still heterogeneity, right? So there's some patients who it probably benefited, some people who it harmed. And so we should feel allowed and have permission, to tailor these guidelines and, everything to our individual patients. But it's going to be very interesting to look at what the downstream complications are of COVID-19. And, we will only know in retrospect what we could have done. But I think studying those long-term, complications is going to be really important. We're giving people a lot of steroids. So that's going to be interesting.
Yeah, I absolutely agree. It's going to be interesting. And I know, my involvement in post-ICU syndrome, but now this post-COVID syndrome and these post-COVID clinics that we have, coming up is definitely going to be intriguing, especially not just the sequelae of the lung sequelae of having COVID, but also some of these neurocognitive changes and whatnot. There's going to be a lot coming out, I imagine. Absolutely. So, Stefano, I think, thank you so much for mentioning, because the strong ERS recommendations are definitely for corticosteroids as well as for anticoagulation. And I know there's definitely been some discussion in the chat about anticoagulation. And I just wanted to point out that CHEST is having a webinar on anticoagulation in COVID-19 on April 1st. So for more information on that and a much deeper dive into that, because that will be more than an hour, will be on April 1st. Well, before I get to a few more questions from the chat, are there any other large takeaways you guys wanted to discuss or point out from changes in the guidelines? Once again, before I get to some of our guests' questions.
I think I'd like to just say one other thing, that's something that's been really important to me in my own clinical experience, and just I'm sure everyone else is sort of feeling this, is the other thing that's kind of new is living guidelines. And that's been something that's been really great. I go to the NIH. I love it because it gives me a sense of the NIH guidelines have these pretty broad, you can get into the weeds, but there's some pretty broad overviews of recommendations. But then if you really want to drill down and see what the rationale was, the difference between guidance and guidelines, it's very, very important. Guidelines there's a very rigorous methodology, like Stefano was describing, to go through with an expert panel, but there's a very rigorous methodology that comes up with those guidelines. Guidance, just about anybody can make a guidance. And it's, just kind of this interim stuff that's not exactly, an evidence synthesis review. So the guidelines and the living guidelines are really key. And I think this is going to really change the way we think about practice guidelines in the future. We don't want to wait 12 years for another pneumonia guideline, for example. So can we make more things living? Practice really is dynamic. It changes faster than sometimes the old traditional way of guideline production. I think that's another thing that COVID has really challenged. So,
yeah. And if I can add something to what Barbara just said, it's important also to remember that now we demonstrate that different drugs should not be used in clinical practice. So first of all, not to harm our patients. So adding drugs, as some of us did at the beginning of the pandemic, doesn't mean that we are doing the best to our patients. And we know that worldwide colleagues have been used different unproven drugs, especially in the early stages of the pandemic. And if you take a look at the literature and also the ERS guidelines, with the exception of steroids and IL-6 receptor antagonists, there is really limited evidence that support any other antiviral or anti-inflammatory treatments that can reduce mortality and prevent complications in hospitalized patients with COVID-19. So repurposed therapies failed to reduce mortality or to improve any other outcomes. And we need to keep doing randomized controlled trials. We need to wait for the results of a lot of very nicely designed randomized controlled trial in the next few months, because this is what COVID-19 actually taught us.
No, I thank you so much for saying that, and I can't reiterate that enough. I mean, I think that's circling back to your initial key messages on, on these guidelines, that now we are able to make, have good randomized solid controlled trials, to really help guide our clinical therapy, so we don't do harm or we don't or whatnot. I mean, 'cause definitely from the beginning, a lot of drugs were just being used. And I think we still need to take that to heart, because there's, I think, in the chats and things that popped up and in talking with colleagues nationally, internationally, it's, oh, what about this? What about that? It's like, we have corticosteroids, we know have quite a bit of improvement. We have, with this, now we have our IL-6 receptor antagonists. And so let's do what we know has been proven, and then if we think something else is out there, let's try to investigate it. But I agree, I think we are now at the stage that we are doing so much better taking care of these patients, and that we need to really stick to our known randomized controlled trials.
And the living guidelines are so accessible now, and I've really liked them for, if you're curious about a medication that we haven't talked about today, for example, the NIH, has a description and really goes over all of the best evidence for around any kind of antiviral, any other medication that people have been trying. And it's really helpful. Even say, for example, a patient, will ask me, what about, hydroxychloroquine? And I can actually, am armed with a lot of really good information. And so I've really reached for the guidelines to really kind of help compress a lot of the evidence and help me sift through it. There's been a lot of evidence to kind of, and of various quality to really sift through. So that's another great advantage of the living guidelines. So
yeah, and I agree, because I know there was a comment earlier in the chat about, how do we disseminate all of these guidelines and all of these knowledge, especially to, other areas or some of maybe our community hospitals that we're in discussion with, that we can't always accept their transfers. But no, I think that's a great resource.
Yeah, that's a great question. And I think another thing that's been amazing about COVID is we've all gone virtual. And I think sometimes that democratizes a lot of the information flow. And so that's hopefully, going to be another positive outcome from COVID-19 is we will have better information dissemination, I think.
No, I absolutely agree. So.
And Casey, I think that there is something in the ERS guidelines that might interest our colleagues worldwide, and I might get some question about that, because we in Italy have the majority of the data, and I'm talking about the use of non-invasive CPAP and high-flow nasal cannula in COVID-19 and prone positioning. This is not based on strong evidence, but I think that at least in Southern Europe or Europe, people are still using this because of several reasons. Especially in the early phase of the pandemic, when we did not have a lot of ICU beds. So there's no big evidence there. We are at the stage of observational studies, and this is the reason why in the guidelines we had just a narrative format, and a lot of these data are heterogeneous, mostly observational, and I think that only three. I was in charge of this part of the guidelines with Anita Simmons and other colleagues, and only very few prospective observational studies. No randomized controlled trials, but we know that as we said at the beginning, there is a recovery randomized control trial comparing standard oxygen therapy with CPAP and high flow nasal cannula, which is currently recruiting, and maybe the data will be out soon. And so, if just looking at the observational data we have so far, although as I mentioned, there is a large heterogeneity. We might think about high flow nasal cannula or non-invasive CPAP through either helmet or face mask in COVID-19 patient with an acute hypoxemic respiratory failure. But we need to think about this only in the absence of an immediate indication for intubation and invasive mechanical ventilation. This is really, really, really important. And also the other point is that when we are dealing with this kind of non-invasive things, these are aerosol generating kind of procedure. So it's important also to remind that we need to use them in a special environmental with people wearing some specific equipment. And all these should not delay mechanical ventilation. We do not have nice evidence coming from randomized control trials. And this is the same also for prone positioning in patients not intubated. So there are some data showing maybe a good effect on gas exchange. If you are using the Puffy ratio, but if you are using the gradient, the alveolar artery gradient, maybe the data are not similar. But we do not have data on impact on outcomes of prone positioning coming from randomized control trials. So this is another brand new field for good research.
Yeah, and I definitely feel like those studies are coming, and that's a whole nother debate about, proning our COVID-19 patients, once again, but if they're technically have ARDS, it's ARDS, and we know that is effective in our severe, that's a whole nother discussion. But I know that there are randomized controlled trials going, well, not randomized, but there are trials going on right now on, tummy time, we're calling it, our patients that are awake, that are on high flow nasal cannula, yes, on very high levels of FiO2, and, or more, I don't think CPAP and BiPAP's included, but yeah, and so kind of what those outcomes are going to be, and I think that's going to be very intriguing. And we have, just observationally, I've found improvement, but it's hard to say observational because those patients probably stick into my head. So we'll stick to science and then come out with those the actual guidelines or the actual evidence, and then we'll see how the guidelines then change based off of that.
Mm.
Yeah, I think the respiratory support and the real fluctuations in our style and respiratory support is really fascinating, right? We started with really, it was a whole different ballgame in April when, there was fear of transmission to healthcare workers. There was the early intubation was really important. There was worry about aerosol generating procedures and transmission. And then we had a social norm of practice for pneumonia and ARDS that early intubation was associated with, better controlled intubation, better, for hypoxemic respiratory failure, there is some evidence to suggest that that's a good approach. But then it's shifted wildly, right? I mean, in my unit, we've got a whole lot of patients on 100% high flow. And it's really interesting. And I think we're learning a lot, but there's probably some advantages to keeping people on high flow. They can move, they can interact with their families, they can do a lot that you can't, they're not getting paralysis and sedation and immobility. And so, but where's the sweet spot? So it's really shifted wildly. And I think all of this kind of nods to context as being so important. And so I have different intubation thresholds. Someone asked about this, even across the street, if I'm at the VA hospital or the university hospital, I have different intubation thresholds because I have different infrastructure. And so if you have the ability to manage patients really well on high flow and be very attentive to them and know when they're getting tired, your intubation threshold is really different from if you're in a hospital that doesn't have as intensive monitoring, similar to the non-invasive, CPAP helmets, for example. Your infrastructure and your organizational setting really impacts what your threshold should be. And so that is a huge thing. Context, they call it, what do they say? Content is king, but context is God. So you have to individualize all of this stuff.
I agree. And I know that there are right now currently ongoing a lot of various different scoring systems to try to figure out, better to try to figure out which patients should be and when to intubate, when's kind of the right timing of it. I mean, I know there was a decent sized retrospective study that came out of Emory last year, critical care med, that showed, that really showed that early intubation had worse outcomes. And so, so there is a decent body of literature that, supporting, delayed intubation, where I agree, right? Early on, we were doing early, sooner than later intubations, but I think now there's a vast body of literature supporting that high flow is, and delayed is, but then, right, what does delayed mean?
Mm-hmm. And where is the sweet spot? Yeah, so that's the.
Well, unfortunately, it looks like we've come to close time. I would like to offer either of you any last remarks or any last word on guidelines or COVID. Barbara, you want to go first?
Barbara.
Oh man, well, I guess I would just reiterate that the dynamism of our data, of our patients, of, this COVID's taught us a lot about how to be a little more nimble than maybe we were before COVID. So I think I'm really excited to kind of experience with all of you kind of how dynamic and nimble we become after COVID. I think it's going to be really exciting. We'll do some really great things to, again, like that dissemination of information. That's a really important challenge. I think it'll be really interesting to see how that goes.
Well, I can echo what Barbara just said, and we need just to wait for nice data coming out. The webinar of CHEST on anticoagulation really important, because anticoagulation is another strong recommendation across different study populations. So along with steroids and IL-6 is another important tool we have in our hands for the best treatment of our COVID-19 patients. And I would like to thank CHEST and all the organizers, Casey and Barbara. It's always nice to join this kind of event. So thank you so much for having me here.
Absolutely. And thank you both, Barbara and Stefano. Thank you, for your insight and, for, to have such esteemed colleagues on here. Thank you so much for taking your time and having your expertise. I think this was a really great webinar. And once again, I look forward to working with you both again. And thank you so much. So at this point, we'll be signing off, and everyone take care. Thank you.
Great. Thanks so much. Thanks for the great comments. Wonderful.
Yeah. Bye, Barbara. Bye, Casey.
Bye. Good to see you, Stefano.
Good to see you.